Välkomna in allihop. Vad roligt att se oss alla i samma rum igen. Hoppas ni har haft lika inspirerande och rolig förmiddag som jag har haft. Jag är nästan hes, vi har pratat så mycket. I'm now going to present for you a woman that I'm very glad she is here. And she's been of great importance to us in Vårdförbundet in the development of healthcare and patient safety. And I think you all have read her research results and you have all heard of her, but few of us have really seen her in real life. So here she is, Professor of Nursing and Sociology, University of Pennsylvania, Professor Linda Aiken.
Thank you so much. I'm delighted to be here. Thank you all for coming. And I would like to formally thank the organization for providing both financial, intellectual, cheerleading support to the Sweden component of RN Forecast. It's really very, very important. And I'm sure that you saw the press on the RN Forecast study here in Sweden, and it was a very global press media coverage. We got coverage in places, I don't know exactly why, but Vietnam, for example, very far and wide. We got a lot of coverage of the study in China, in South Africa, in Australia, and New Zealand. So everyone was reading about our results, and there's quite a bit of interest that continues on, and we're following the media. But I think the story is what we would call having legs, which means our study and its findings touched a chord with people in countries everywhere, not only nurses, because the media coverage were in the major newspapers and radio and television in all of our countries. So clearly the public is interested in what we found and the relationship between the workforce in hospitals in this large study and outcomes for patients. So today my topic is a broad topic, the impact of nursing on quality of care and patient outcomes. And I'm going to be focusing on RN Forecast for the most part because that's Europe-based, and of course Sweden is in that study, but also bringing in some other research from some other countries as well. And I'd like to organize my presentation so that I share with you some findings. These are findings that are just really highlighting some of the many things that we are finding and will continue to find from RN Forecast. And then have a discussion period at the end so you could give me some feedback on things you would like to know. And so then we could consider whether we could use the data that you've all helped collect, both as respondents in our survey and your organization and helping with the funding. So are there questions that you have that you think we might be able to address through our future analyses? So I know you know about the RN Forecast study because your organization was a prime supporter of it, but I just wanted to say in the kickoff a little bit about what it is. Even though it's a big survey of nurses, it's not really a study of nurses. And this is very important because we had a bit of a debate yesterday. We were over at the Nobel Forum. By the way, did you get the tweet that's now gone around the world that Aiken suggests that RN Forecast should get the Nobel Prize in Medicine? So that's out there buzzing around through the Twitter network and the tweeting and everything. But it's not one of the debates we had yesterday from some folks there, researchers, isn't this a little self-serving for nurses to be doing this study? Well, it's not really a study about nurses or for nurses. The study is designed to use nurses to inform us about what is going on in hospitals, because nurses are at the nexus of everything that happens in hospitals. They're obviously at the patient interface. They communicate with physicians. They are communicating with management. They're dealing with all the different service lines and all the other services in the hospital. So if you were going to ask yourself, how would you find out what's really going on in a lot of different hospitals? I can't think of a better way to do it than ask the nurses that are providing clinical care in those hospitals. So the design of the study is basically to use nurses, lots of them, 34,000 of them, as informants of what is really going on that is relevant to patient care in over 600 hospitals across 12 countries in Europe. So when you talk to people and when we talk to one another, I think we ought to keep ourselves on the talking point that this is about the performance of hospitals. This is what we're interested in. And that's why it's in the public's interest to know what we found. And that's why I think the media across the globe has been covering it. Not about nurses, the self-interests of nurses. It's really about patient safety and patient outcomes. So in brief, we have the 12 countries. We have all 3 of the Nordic countries, which makes it very interesting. We studied 617 hospitals and basically all of the hospitals in Sweden. We have information at the unit level. We studied medical and surgical units as a way to kind of focus and have some commonality on the kinds of patients that we're studying. And so we link the patient outcomes to those specific units using existing information on, for example, mortality rates that we get from government or administrative sources. So throughout this whole large study, we've done something really quite heroic. This is why I think it deserves a Nobel Prize. In addition to its relevance to patient outcomes, is that there's never been a study on any topic that's taken patient outcomes data for 500,000 patients across 12 countries, well, really 9 for mortality, and taken their different systems of collecting data using ICD-9 codes, ICD-10 codes. Some countries use their own classification, and mapping them all together so that we are studying the same kind of patients in every hospital across all these different countries. So scientifically, it's never been done in any topic, and nurses have done it for the first time. So just an overview. Really, hospitals everywhere are challenged by many different things. I know that you're discussing these at your meetings. So there is no country that I know of, and we've now studied about 30 countries with this approach. There is no country we've ever studied that doesn't have substantial challenges in the hospital sector that has implications for patient safety and patient care. So here are a couple of dimensions that you can briefly scan across the countries that we studied that have to do with the quality of care. We asked nurses to give us their ratings of the quality of care on their units. And by the way, there's a whole lot of science that underscores these different measures that I won't talk about today, but we've validated, for example, that clinical nurses at the bedside's appraisal of the quality of care is very closely associated with the actual patient outcomes using independent objective data from patients. So what nurses say is an accurate portrayal of actual quality of care and patient outcomes. We're looking at, again, nurses' assessments of patient safety, and using a measure that's been internationally validated, we're asking nurses to give their hospitals a grade on patient safety. And then we look at some nurse outcomes as well, many of them, but here you can see we're looking at burnout, job dissatisfaction, and intent to leave. And the reason we're looking at nurse outcomes, along with these patient outcomes, is they're connected with one another, and that's what we show in our study. Now, my headline is that hospitals here in Sweden are not the best and they're not the worst. So on most of the dimensions that we look at, if you look at hospitals as a whole and on average, they're not the best, they're not the worst. And on some dimensions, they look better than others, but they're kind of in the middle of the pack in Europe. The only thing that I think is kind of worth pointing out, though, from a comparison of is any country doing any better than any other country? Well, on one dimension, I just like to point out here, we put the United States here on as a comparison, and the United States doesn't do any better than Europe does on patient safety and a lot of other things. But the one thing that I'll come back to if I have enough time is substantially fewer nurses say they're going to leave their jobs in hospitals over the next year compared to all the countries in Europe. And the US has done some things to help improve that, which I want to get to. Because if we have a problem with recruitment and retention, we have nursing shortages, vacancies, costs a lot of money for hospitals to keep recruiting new nurses, and the chaos that's created undermines continuity of care and a number of quality issues. So having a more stable nurse workforce is related to patient outcomes. So on that dimension, it looks like the US may be doing a little bit better, and we'll look at why. Now, when we did our press release and we talked to the press everywhere, they immediately wanted to compare countries to each other. They wanted to know, what is the best country in Europe? Well, I showed you this slide that shows that all the countries, if we look at them, have challenges. So that's really not the issue. You know, is there a country that's better than another country in Europe? The big policy issue is that within every country, there are good hospitals and there are bad hospitals. So that the variation on every single dimension that we looked at is greater within countries, across hospitals within countries, than between countries. So this is just an example of something that I'm going to kind of bringing back to you. So it's not whether you have better outcomes than Norway, it's why do you have so much difference across your own hospitals in outcomes? Because policy takes place at the national level for the most part. That's what you have control over. And it suggests that that is where we really need to focus. In some things, the European Union could be helpful, the Parliament. On other things, you know, these are national discussions. So here, for example, we're showing that there's tremendous variation in quality of care across the hospitals in Sweden. So we've asked nurses to assess quality of care. We have about 79 hospitals in a study in Sweden. And so this is looking at the proportion of nurses in each hospital. So every little bar here is a hospital. And so we look by hospital to see what proportion of nurses say the quality of care in their hospital is either fair or poor, as compared to good or excellent. And so in some hospitals, not a single nurse would say the quality of care is only fair or poor. In some of these hospitals down at the bottom. But some of these hospitals that are up at the top with these big things, like 59% of all the nurses that are working in those hospitals with the biggest, longest bar say the quality of care is not good. Okay, so there's an agreement among the nurses that work in those hospitals that the care is not good. So this is a way of showing that, you know, there's a pretty good consensus of nurses in hospitals that some hospitals in Sweden provide better quality of care than others. Same thing on patient safety. Again, we asked the nurses to give their hospital a grade on patient safety. So the proportion that say that patient safety in their hospitals is fair or poor resembles that same shape of the curve that I just showed you on quality of care. So none of the nurses in some of your hospitals say that patient safety is only fair or poor. And in the hospital with the biggest problem, 38% of all the nurses at the bedside in those hospitals say that their hospital should get a fair or failing grade on patient safety. So, you know, again, pretty good evidence that something is going on in the hospitals that's different. Now, normally when you have well-qualified professionals that are making these judgments that suggest that hospitals are different, there's some consequences for the public. And that's what I'm going to come back to all the time, because what we're studying is really about what's in the public's interest. So as nurses say there are quality problems and safety problems in your hospitals, there's also a huge difference in the mortality across your hospitals, remember each of these bars is a hospital in Sweden, and they are reflecting the mortality rate for a very well-defined group of patients, which in this slide are patients recovering from common surgical procedures. So we're studying common surgery, even though the mortality is low overall, because most people that have common surgical procedures like, say, joint replacements or appendectomies or some mostly elective surgery, they don't expect to die. And physicians, for the most part, don't undertake these procedures if they expect the patients to die. These are not life-saving heart transplants, et cetera. These are common surgical procedures. And the overall mortality rate is about 1 for Europe for these procedures. But the mortality rate here in across your hospitals ranges from less than 1 to the best hospitals to almost 3.5% of patients die. So do you think the public in Sweden realizes that there is a 4-fold difference in the mortality across the hospitals? I don't think they realize this anywhere, because the public generally thinks if you go to the hospital that you're going to get good care. I mean, they just assume it, and especially, I mean, they might think about it if they had to have some kind of specialty procedure. They might kind of look into, well, should I go to a special hospital for that if I need a transplant? But going in for general surgery, they're going to assume their local hospital is going to be good, but the assumption is not correct. And this is the way I think we get the public's attention, saying, I mean, the public has to realize that healthcare is not, this doesn't have the same outcomes everywhere. And this is why they should care about what's going on in hospitals. So here you are with very different mortality rates across your hospitals, and so we want to know why. And so we start asking a series of questions about what explains why hospitals in the same country have such different mortality rates. This is another kind of representation of where you stand among the hospitals that we studied across the 9 countries in Europe where we could look at mortality. So the gray is a bar for every hospital in the study across 9 countries. And the hospitals in Sweden are orange. So the point of this slide is to say that you have a continuum of mortality across your hospitals that represents, you know, the mortality in Europe, that you're not any better or any worse than Europe taken as a whole, but you have a huge variation in mortality. And this is true for every single country that was in our study. So that's why I say that it's more important to look at the variation across the hospitals within countries than to be paying too much attention to does Norway have lower mortality than you do. Norway has just as much variation in the mortality across their hospitals as you do, and that's kind of the issue that's more relevant to the public. So one of the things that we are doing that's unique, that comes from our whole experience as being nurses, really for myself as a personal story, I think I got a good education as a young nurse. I went to work in the teaching hospital of my university. I thought it was a good hospital. I thought I was, you know, reasonably competent for a young nurse, and as we did in the day, I was a charge nurse on a big surgery unit that was thoracic surgery and a lot of other complicated things, and there was one other nurse besides me, so we had, you know, 15 patients each or something like that. And I realized that there's something wrong with this. It doesn't matter how good I am personally. I can't really keep those patients safe. First of all, I can't even see them. I can't even, you know, appraise them. I can't really do any surveillance across that many patients. So that's when I personally got interested in what is the effect of the organizational context of care on the outcomes of nursing care in particular, because nurses are all part of complex organizations. And so our overall hypothesis is that over time, that we have more and more safety problems in our hospitals because of the organizational complexity of decision-making, issues of workloads, communication challenges. And so we wanted to measure what is it about the organizational context and can it be fixed in a way that would actually both improve nurse retention and recruitment to hospitals, but also importantly, improve patient outcomes. So when I talk about the nurse work environment, we spent about 25 years developing a survey-based measure that nurses fill out for us, assessing really the culture and the climate that affects everybody that works in hospitals, not only the nurses, but it also affects what physicians can do and not do and so forth. And so these are some of the elements that we measure. I just wanted to point this out. So when I use my shorthand that says the work environment, I mean, are there enough nurses? From the nurse's point of view, the nurses say there are enough nurses to provide reasonable quality of care in their environment on their last shift. They're commenting on their last shift in this. Do they participate in hospital decision-making? Is there any nurse executive? And is the nurse executive in the decision-making group? So is there some communication line that nurses at the bedside have to communicate problems that are likely to even be passed on to top management? Then how responsive is management? I don't have a slide on this, but it's interesting to know that every country we've ever studied, across 30 countries, about 75% of nurses say management is not responsive to the problems in patient care that we identify. It's across developed countries and rich countries and countries with a lot of nurses and not a lot of nurses. There's a big disconnect between what nurses think is required for patient care, the problems they identify, and the capacity of management or willingness to actually fix them. And I've gotten very interested. I've been working with some people at my business school. We have a highly ranked business school at the University of Pennsylvania, the Wharton School. Some of you might recognize that name because they're world known. And one of the things my business colleagues kind of picked out of our findings is that nurses are masters of the workaround. You know, the idea of the workaround where you see a problem and you figure out how to get around it, but it never gets fixed. And so then over time, nurses are spending more and more of their time working around problems. So my example of something that's bothered me forever since I'm a surgical nurse is in our hospitals in the US, nurses spend a lot of time looking for pillows. Now, I don't know if this is a problem here, but when I talk in the US, I say, is anybody spending a lot of time looking for pillows? And all the nurses are like waving their hands and everything. And it turns out that materials management, this is what we call in our hospitals the department that is supplying, the material that we need to take care of patients, is assuming that every patient needs 1 or 2 pillows. Well, in surgery, you're positioning these patients after surgery, and on some surgical units, you need an average of 6 pillows. And so all those nurses that are only getting 1 or 2 pillows are all stealing, from other floors and hiding them. But the net result is that there's never the right number of pillows ever. In all of my years as nurses, everybody's still hunting down pillows, and the same thing for stretchers and wheelchairs and you know the whole thing. So my business colleagues have pointed out that nurses are the masters of the workaround. And we kind of pride ourselves on that we could figure out that we're good problem solvers and we can figure out how to solve these problems. But what they point out is we're enabling poor management decision making because we figure out how to work around it. So the full consequences of these things that happen in hospitals and have been happening as long as we can remember never get fixed because we work around them. And so it's a different way to think, it's kind of like the codependency idea, are you enabling somebody else's bad behavior through whatever it is that you're doing? So I'm kind of thinking about this, but I think it was a very interesting comment. So on the issue of poor work environments, You can see here that a substantial share, the majority of nurses really, in most of the countries we studied, including the US, say that their work environment is only fair or poor. And in Sweden, about 57% of your nurses at the bedside characterize their work environments as only fair or poor. But then again, we find in Sweden and every other country some hospitals in which the nurses agree that they do have good work environments, and some hospitals in which all the nurses that work there, the vast majority of nurses say, yeah, this work environment is really poor. So, for example, overall, the mean number of nurses in Sweden that say that the work environment is poor in their particular hospital, 55%. But in some hospitals, only 9% of the nurses say the environment is bad. And in these ones with the really long bars, 89% of the nurses that are working in some of those hospitals say the work environment is only fair or poor. It's a pretty, I think, valid idea that work environments are differing across the hospitals in the country. Now, why we care about it is not so much that, I mean, we do care about the outcomes for nurses, but we're not being self-interested in caring about this. For example, we look at every country that we've studied, and there's a relationship between better work environments and lower burnout among nurses. Now again, we're nurses and we're concerned about the well-being of our members, but the main reason that it's in the public's interest for there not to be burnout among nurses is the higher the burnout, the higher the medical errors, the lower the patient satisfaction, the worse all the patient outcomes are when nurses are burnt out. And you know, you can just imagine this yourself. You think about anything you're doing. You try to get on your computer, you're tired and burnt out, you make mistakes, like balancing your checkbook. I mean, people make mistakes under those circumstances. So you see, in every single country, just how to interpret this is every one of these little dots is a hospital. So we have combined all the Nordic hospitals together, and I don't seem to have a pointer on my thing that I know of. But anyway, you can see the Nordic hospitals there, and as the work environment gets better and better in each hospital, you see the lower and lower burnout. Same thing with the hospital safety grade. As the work environment gets better, and again, this is across all these countries, so we're beginning to identify common things that are common to every country that we study. So this is not just something in Sweden, it's not just something in the US. And the reason that this is important is it's taken us a long time to convince policymakers that some of the things that we're finding in our research are really meaningful. And part of this is because you didn't do the study here. And I don't believe it if you didn't do it in Sweden. So we actually started some of this work in the US earlier. And European policymakers, managers, acted like there's no relevance to anything we find in the US to anything that happens in Europe. Well, it's absolutely wrong. And so one of the reasons why we're doing all this international research now is to convince decision makers that despite the fact that there are many differences between countries, economies, policies, that some of these things about hospitals are common across all of our hospitals. So if we're concerned about patient safety, and now most all of our countries, WHO is promoting this, et cetera, that we should all be concerned about patient safety, that we cannot have a safe environment, this would suggest, if we have such poor work environments in hospitals. So we could talk all day about patient safety, but one of my critiques of patient safety is that we're reaching out for these magic bullets. So somebody's developed an idea that will make care safe. So we'll just take checklists. So surgical checklists. If everybody fills out the checklist, we won't have any more medical errors in surgery. It's not true. All the research shows it's just flat out not true. And every single time we develop the so-called magic bullet, maybe you can do it for a while, in a controlled environment where everybody's focusing on it, and then you can't sustain it over time. Just on the checklist alone, it's actually my colleague, Peter Provenost at Hopkins, that developed this idea of surgical checklists, did an interesting study, showed they could reduce errors after surgery. Ontario, the province in Canada, just introduced it province-wide, had absolutely no effect. Because our data would suggest that if we don't fix all this variation in the work environment, the checklists are not going to work. They don't magically make something happen if the fundamental underlying capacity of the hospital is not good. So you guys with me? So this is, an unpopular view, and it's kind of inconvenient because it suggests to people in the patient safety area that all of their little great ideas are really not going to work as long as nursing is so chaotic, because nursing is a surveillance system and the implementation system for all these things they're thinking up. So let's take a look at hospital ratios. Staffing, this is controversial. Staffing costs money. None of us can afford our healthcare system, so we're all trying to figure out how do we get the best value out of the money that we're spending. And so if we look at staffing, we see there's a huge variation in the average patient-to-nurse ratio across the hospitals in Europe. And you can see, again, that Sweden doesn't have the worst patient-to-nurse ratios, but it doesn't have the best either. So there's a lot of variation there, but more importantly, and I don't know if you were aware of this before we did the study, there's huge variation. You have a question?
Excuse me, I didn't understand how many patients every nurse have in the last picture. Can you explain it a little bit more?
Okay, so this is, what we do is we ask 34,000 nurses, on your last shift, how many patients did you take care of? So the nurse can be, and this is only in medical surgical units, this is not the ICU. So the same kind of units are studied in all the countries, but it's 24 hours a day. So for you, it would include the night shift and the day shift averaged together, because some countries staff more uniformly around a 24-hour period, and some have a big difference between night and day. But what this measure is, it's an average. So we take all the nurses, basically their workloads, and we average them together for a particular hospital, and so that's the number. So the way you would interpret this for Sweden is that the average nurse in a hospital in Sweden on a 24-hour basis, so it's neither day shift nor night shift, the average over a 24-hour period would be a little over 5 patients each. But what that covers up is, my next slide, which is that isn't really all that meaningful, because the staffing ratios vary in hospitals across the country using that particular measure, from hospitals where nurses are taking care of, on average, less than 4 patients each. This is not intensive care now, remember. So this is on a general medical or surgical unit. So on average, there are some hospitals in your country where the patient-to-nurse workload is about 4. And there are other countries, also general medicine and general surgery, where nurses in those hospitals on average are taking care of 9 patients each. So there's 100% difference in the workload of nurses across the hospitals in your country. Now, again, think about, you put this in a newspaper, do you think the public would be interested? I would be interested if I were a patient. That this is kind of starts raising the question of, well, doesn't this kind of distribution line look pretty similar to that mortality slide you already showed us? And I wonder if in those hospitals where nurses take care of twice as many patients, are those the same hospitals that have the highest mortality, right? These things start going together. And this is, of course, what we find in our study. Before I show you some of these, I'll just also take up the issue of skill mix. Because in addition to what's the workload of a nurse, another factor that can be modified by policy or by management is what is the proportion of professional nurses in all of the caregivers in a hospital. So how many unlicensed assistants do you have versus how many nurses? And so again, there's not quite as much variation in what we call skill mix. And my definition of skill mix is the proportion of the nursing staff caregivers who are nurses. Does vary by hospital. And in Sweden, on average, in your hospitals, about 58% of the nursing services caregivers are nurses. So a little over half are nurses, and a little less than half are not nurses. But this is kind of important to the public, too, because can they tell who's a nurse and who's not a nurse? Because half the people at their bedside are really not nurses. Maybe that has some consequences for their care. Now, here's the skill mix difference again. Even though I showed that there wasn't that much difference in the average skill mix by countries, again, you have huge differences in the skill mix in your hospitals that must be a result of management in those hospitals making some decisions, because in some of the hospitals, only 42% of the entire nursing caregiving staff are nurses, but in some hospitals, 72% are nurses. So again, there's a lot of difference in both the ratio of RNs to, or I'm not sure you call them RNs, but nurses to patients, and also the nursing skill mix. So what difference do these staffing differences and the work environment have for patient outcomes? And this is where, we get to what matters for the public. Well, we're going to look at mortality in a minute. We couldn't study mortality in all the countries because they didn't have data systems that would allow us to compare common patients, which is very important. So we actually interviewed the patients themselves. So in addition to surveying nurses at the study hospitals, in most of the countries, we interviewed patients, and we used a standardized international patient satisfaction survey. Now, a number of countries and hospitals within countries are surveying their patients now in patient satisfaction. The WHO and all of our international organizations have now said, I think personally for good reasons, that patient satisfaction is an important component of quality of care, and we can't talk about quality of care without talking about the patient experience. There were too many different surveys going on across the countries for us to look at common measures, so we used a survey actually developed in the US by the NIH with about 10 years of research evidence. We translated it, I think, into 12 different languages in RN Forecast, and we basically surveyed the patients on the units that we were studying. And so there are a couple of global measures that we are particularly interested in because, again, this is not, am I satisfied with nursing? Because we really want to know how important is nursing for patients' overall satisfaction with the whole hospital. So we used two measures. We asked the patients to rate the overall quality of their hospital on a 10-point scale. And 10 is the best and 1 is the worst. And so we say that patient satisfaction at the 9 or 10 level is the best satisfaction, and anything below 9, you could improve the patient satisfaction in those hospitals. And we also asked them, would they be willing to recommend their hospital to a family member or friend who needed care? And so that's our other global measure. So we found that actually an interesting thing is that nurses and patients totally agree on which are the best hospitals. We never knew this before we linked these together. So we asked nurses, you know, all these issues I've been talking about, and would you recommend your hospital? This is something we specifically asked the nurses in Europe. Would you recommend that another nurse work in your hospital? And then we asked the patients, would you recommend that one of your family members get care in this hospital? And there is a complete agreement on the nurses that would recommend their hospital as a place to work and the patients that would recommend their hospital as a place to get care. So that is very telling. And then we also look at, do these factors that we've been looking about staffing adequacy and the quality of the work environment, do they have any relationship to patients? We know they're related to some nurse outcomes like burnout and satisfaction, but are they related to patients? And the answer is yes, those factors, nurse staffing in particular, and the quality of the nurse work environment are the two biggest predictors of patient satisfaction among anything you could measure in healthcare. I'm not just talking about the most important things about nursing. They are the most important things, period. So I have some colleagues, for example, that at Harvard that started down the road of, I think they were thinking that they were going to show that the quality of medical practice is the most important thing and how patients rate their hospitals. And they were shocked to find out, a paper they published in the New England Journal of Medicine, that really was the nursing care that was more important to how people perceive their care and their experience in the hospital than anything that has to do with doctors. I'm not saying doctors are not important, but in the perceptions of patients, that's the public we're responding to, it's all about, are there enough nurses? Is the environment working so that I have the sense that people know what my needs are and they're taking care of them? So this is where we get the difference between patient satisfaction and these chaotic environments that don't have enough staff, and they have all these people working around things, and hospitals that have poor work environments. We know from operations engineering research in the US that nurses are stopped in mid-task, and this is in the US, but I have no reason to think it's any different in Sweden. They have to stop their care in mid-task once an hour because something in the hospital environment is not working. They don't have the right drug and the right dose. They don't have the right equipment. The right food's not there, on and on and on. So they're stopping in mid-task every hour. Well, just think about the consequences for patient safety. If you have nurses taking care of very sick patients and they're having to stop at mid-task, just take medication administration alone. Do you want any nurses stopping while they're in the process of figuring out, you know, these medication dosages, et cetera? You want them to stop because something else is not working in the environment. So these things are all at the heart of our patient safety problems, and patients can perceive them in their patient satisfaction rating. So I haven't said anything about nurses' education, and this is something that many countries are debating. And as you well know, some countries have gone to standardizing nursing education at the bachelor's level. There are quite a few countries now. Australia, New Zealand, 2 countries in Europe that were in our study, both Spain and Norway, Latin America, a number of countries. There are many countries that have done this, and there are many countries that haven't. So all of our countries that are paying any attention are saying, does it really matter? And there's kind of what I would call a myth that's alive and well in nursing. And the myth is that whereas doctors have to have long years of education, and they need science-based education, that for nurses, their experience is more important than their education. And so we wanted to test that scientifically to say, is that really true? Doctors need all this education, but it only matters how many years of experience. And so we started doing this research to address that, because there's all this variation in the percent of baccalaureate nurses, and it's not only at the country level, but unless countries mandate or standardize entry into nursing, there's a lot of variation at the hospital level. So here again is the variation across Europe in the proportion of nurses in each hospital. Remember, each one of these lines is a hospital. So they're going all the way in Europe from the hospitals we studied, hospitals that don't have a single nurse with a baccalaureate degree, to hospitals that have 100% of their nurses with a baccalaureate degree. And remember that orange are your hospitals in Sweden. And so you can see that because your country doesn't mandate this, that there's a lot of variation. And so in Sweden, the average proportion of nurses with a bachelor's degree is 54%, but some of your hospitals only have 27% of nurses with a bachelor's degree, and other hospitals here have 76% of their nurses with a bachelor's degree. Well, does that have any consequences for patient outcomes and relative to experience? So we decided that we wanted to focus on that question because it was something that was also being debated in the European Parliament. As you know better than I, there's long been, since the beginning of the European Union, this idea that there should be mobility in occupations across the countries of the EU, and also the products produced should be similar. So that means that healthcare in Sweden, the public should expect to get similar healthcare in Sweden as in Norway, et cetera. So the way to get to that is to think about standardizing the requirements for education in all the various occupations. Many of the occupations, as you know, back when the European Union was established, were set at the baccalaureate degree. But nursing, which is not unusual, kind of got exempted from, this is an American speaking, so you guys can correct me. My interpretation is that nursing was exempted, and so the level and the goal of standardizing across Europe was set at only 10 years of general education, plus vocational training. And until last October, that's what it was. And I'm happy to say that I think our study led to a change in the European Parliament, and now another pathway that's recommended, which is 12 years of general education and leading to a university science-based education. But how we got there is that we looked at this variation in education across the 300 hospitals across the 9 countries, and we said, are there any implications for the outcomes for patients? And so we found actually that moving from the worst staffing, we try to put these things in combination, so the nurses that take care of the most patients each, and the fewest of them that had a baccalaureate degree, had much higher mortality. So then we looked specifically at what is the real mortality effect of all this variation in both staffing and education that we find across these hospitals in Europe. And we concluded that for every 1 patient added to a nurse's workload is associated with a 7% increase in mortality for patients that were recovering from common surgeries. And likewise, every 10% increase in bachelor's education was associated with a 7% lower mortality. So if you kind of put that together, patients in hospitals that had 60% bachelor's nurses, and where nurses cared for no more than 6 patients each, had half the mortality rate of hospitals that had only 30% nurses with a bachelor's degree and took care of 8 patients each. So then we kind of projected those scientific effects from all of these regression analysis, et cetera, and estimated, well, what would be the net impact if all the hospitals we studied and the other hospitals in these 9 countries would all come up to the level of having 60% nurses with a baccalaureate degree and not taking care of more than 6 patients each. We estimated that every year, 3,500 patient deaths in hospitals could be prevented. These are really big, big numbers. So just to say that again, just by setting a standard of the proportion of baccalaureate nurses and what seems to be a safe standard of staffing, which is 60% BSNs, which is less than a lot of countries already have, and taking care of not more than 6 patients each, which is also less than, or more than really some of your hospitals already have, could result potentially in preventing 3,500 deaths a year. And that's just in the 9 countries. So if we took all the countries in Europe, we'd have even more. So it's a very big number, and this, I won't take you through this, but this is the scientific evidence that shows that the deaths per 1,000 discharges can be actually cut in half by reducing the number of nurses that each patient takes care of from 14, which is the highest number that we have that's not a total outlier, down to 4, which is the lowest level. You cut, and we're controlling for all the other things that are going on. This is not just looking at this. We're taking into account teaching hospitals, non-teaching hospitals, urban, rural location, the number of doctors, et cetera. And this is how big the effect of differences in staffing has on mortality, and likewise the same thing on education. A very big difference in mortality can be attributed only to education. So we said, took up that idea of the myth. We said, well, is it really true that experience trumps education in nursing? And the answer is no, that once you take into account nurses' education, overall experience has no impact on mortality. Which is not the same thing to say that an individual new nurse is not, doesn't have issues compared to an older nurse, but across the whole workforce, experience does not contribute to patient outcomes once you take into account education. So education, of course, can be changed. And so a lot of people yesterday, we had a debate over at Karolinska about, aren't these just cross-sectional associations you're finding? And how would you know that if a hospital really hired more nurses with a bachelor's degree, that they would get better mortality? And so some of these studies we've already done in the US. So we've done them over time. We have panels now. We started before you did in this kind of research. So in my program, we're now, for the third time, going back to the same 680 hospitals. And so we can see what decisions they made over time and what effect it had on their patients. So we can show that hospitals that over time employ more bachelor's nurses have lower mortality than other hospitals. Now there's another issue besides better patient outcomes that's associated with education that I just wanted to mention, which is not always obvious. When I was talking to our congressional staff, I pointed out that one of the biggest problems we have in the US, and I'm not sure if there's a problem here or not, I would suspect it is that we're projecting a very big shortage of faculty that could really cripple our supply of nursing as a future, because we don't really project that we'll have enough faculty for the future. So we have 3 million nurses. We have to have a lot of faculty to produce enough nurses to replace the 3 million nurses, and it will probably grow over time. And we also are becoming more and more dependent upon nurse practitioners and clinical nurse specialists with an expanded role by primary care and other services in our systems. We don't have enough of them. Well, there's a relationship between nurses' initial education and how many nurses ever have a master's degree, and thus in our setting can ever be teachers or ever be specialists. So this is a little bit of a complicated slide that I had in the New England Journal of Medicine, but it points out that most people can't keep going back to school all the time. There are probably a lot of people in this room that have gone back to school and gotten additional degrees and certifications, but life goes on. They're babies. There are other things that are difficult to manage, and nursing is a predominantly female occupation. So there is an implication for your initial nursing education as to what your final education would be. And so if you take the lowest now acceptable rate of nursing education in Europe, according to the EU, which has 10 years of basic education and vocational education, the number of nurses that will ever go from that to a master's degree is very, very small. This is what we're finding in the US. So in our world, the number of nurses, which are most of the nurses now that are being trained in the US, are in associate degree programs. So they not only they have to get a master's degree, then they would have to get a bachelor's degree first, then they have to get a master's degree. and people can't get 2 additional degrees. And so the net result is that the stream of people to these jobs that require master's level preparation is very tiny for a group that's as large as nursing. So this is another reason why it's in the public interest to standardize nursing at a higher level, so that a higher proportion of nurses that ever go back for additional education will get to that master's degree, which in our country, and I suspect ultimately in yours as well, will be one of the most in-demand roles for nursing, as it is around the world. And you're not going to have enough people there unless you expand that base of baccalaureate students as well. I thought it might be interesting to bring in some of the policy changes that this research has brought about in some other countries to suggest what might be possible here. When we did a similar study to our forecast in the US and showed a tremendous effect of baccalaureate education on improved outcomes for patients, it was in all the newspapers, et cetera, immediately our organization of nurse executives, these are our nursing directors of our hospitals, who are the ones that make the decisions about what kind of nurses to recruit, looked at the data and said, we have to act on this. This is evidence we've never had before. And so, in a very controversial move, they said the baccalaureate degree is the desired degree for hospital nurses in the US. And they started preferentially hiring only baccalaureate nurses. And so once the employers did this, led by the nurses, by the way, the Nurse Executive Organization is a constituent member of the American Hospital Association. The American Hospital Association has always been in favor of the shortest, briefest education for nurses. And so the nurse executives who were part of that organization went against their own organization to say, no, here's the evidence, we're going for a baccalaureate standard. And as soon as the employers started preferentially recruiting, then the nurses went back to school. So we have 100,000 registered nurses now getting their bachelor's degree. Everybody's like working on the bachelor's degree. Because in my community, Philadelphia is the 5th largest city in America. You cannot get a job in a hospital as a nurse if you don't have a baccalaureate degree. Okay, so nurses have changed the whole market, and the whole country is going without any laws or regulation or anything formal, because nurses decided to take hold of this and do it themselves. And so now coming behind this, we have our National Academy of Sciences recommending that by 2020, a minimum of 80% of all the nurses in the US will be baccalaureate prepared, and we haven't changed any law, and it's happening. So it shows that, you know, we can be in control of some of these things. So I think there's an implication here for Europe with a debate that's still ongoing in the Parliament about the standardization of nursing in the EU. So whereas, and I think our study, even before it came out in the Lancet, we fed it to nurses who took it to the Parliament, was part of the reason why there was this second pathway approved last October for 12 years of education and baccalaureate nurses. But they didn't delete the other recommendation. And I think the reason that this is important is, if you look across Europe, it suggests that some nurses in Europe don't have access to baccalaureate education. How would you ever explain why not a single nurses in 48 hospitals in Germany had a baccalaureate degree? They must not have access to baccalaureate education. So you start thinking about it as, you know, that the opportunity may not even be there for nurses to make this choice. So hopefully you'll be active in the future on the continuing debate in the European Union. I just want to end briefly by saying I think the next agenda that we want to take up in our forecast, which is important, and now taking these findings and mainstreaming them into practice and policy changes, is to translate them into the business case for doing these things. So there's, again, the U.S. has kind of got a little lead on this because we basically have a private system. In order to get anything done, we have to convince managers and big health systems it's in their financial interest to do things. So we have a lot of good research that begins to set the stage to suggest that we could also do such research in Europe, and also because we have found already that there's so many commonalities between what we find across countries that some of this research that's already been done in the US is certainly already applicable to Europe. For example, we find that every 75 cents of every dollar spent on improving nurse staffing in hospital is returned to the hospital flat out in reduced expenditures for patients because of all the expensive complications that nurses prevent by having better nurse staffing. And that paper's out there. We need to replicate that in the US. Additionally, hospitals in the US save millions of dollars by having appropriate staffing, a better work environment, because nurses gravitate towards those hospitals and they have lower turnover rates. And we estimate in the US that turnover rates are costing millions of dollars, that in the US context, and we have to do this here, that it costs the hospital the average salary of every nurse that turns over. By the time they find the next nurse, they pay for agency nurses, they pay overtime, et cetera. So there's a lot of money to be saved in overtime. We also find, as part of the business case, that hospitals that have a good work environment and improve their staffing get better value than hospitals that have poor work environment that spend money on staffing. I'll show you this in just a minute. On the issue of education, hospitals are not paying to have more educated nurses, which has a kind of negative aspect to it, but it's kind of positive for change. It may cost your countries more to make it possible for nurses to get a baccalaureate degree. It doesn't cost the hospitals anymore, because for the most part, they're not paying a premium for having more educated nurses. So it's what I say to our hospitals: you're getting a big benefit, it doesn't cost you any more. You should, go to a baccalaureate education. So here's an example of how these things fit together in a business case. So we looked at whether you get the same impact on mortality from improving staffing in a hospital with a poor work environment and a good work environment. So what we find out is if you have a poor work environment in your hospital and you improve staffing, it has a minimal effect on improving patient outcomes. But if you improve staffing in a hospital with a good work environment, you get an even bigger effect than we ever imagined on improving outcomes, which starts laying the groundwork for comparative effectiveness research to say to hospitals, first you improve the work environment, and then you improve staffing, because that's where you'll get the most value. And so then we're looking at what are the big cost issues in our environment. You have to figure out what they are in your environment. Hospital readmissions are costing us a fortune in the US, billions of dollars a year. Now, for heart failure, 25% of all the elderly that go into a hospital with heart failure are going back to the hospital in 30 days. So now our government's penalizing hospitals that have excessive readmissions. And so we just published a paper saying, does nurse staffing and the work environment have anything to do with the number of hospitals penalized for excessive readmissions? The answer is yes. And particularly the hospitals that are penalized at the maximum have poor staffing and poor work environment. So we're trying to make a case that hospitals, it's costing you for not fixing nursing. And then I want to end with a final note, just briefly, which we could go back to and discuss in the discussion period, is one of the reasons why I think the U.S. doesn't have as many nurses saying they're going to leave in a year. There are multiple factors. But we have succeeded in improving the work environment, and one way we've done it is through the magnet recognition program. That is an initiative. You can find it if you don't know about it by just Googling magnet hospitals. We kind of took the tack in research looking at the same phenomena that I've shown you today about your hospitals. There are some hospitals in your country that are good. Well, what are the common things that they share that make them good? And then trying to define what those are so you could replicate them in the other hospitals. So this is what the magnet program did. It found hospitals that were successful recruiting and retaining nurses, even when other hospitals in their labor markets had nurse shortages. And so then they developed a blueprint of how other hospitals could develop these successful strategies to improve the work environment that these successful hospitals already had. And that became this now voluntary accreditation program that was formerly in the US, but it's now international, called magnet recognition. And it's a blueprint that any hospital, and we've shown through research that any hospital that takes a blueprint and takes the steps. It's nurse-driven, it's a staff nurse-driven, so sort of from the people at the bedside up instead of a top-down kind of idea. So having more participation of caregivers and decision-making and so forth is all laid out in these blueprints that any kind of hospital, big or small, rural or urban, if they follow the plan, they get a better work environment and they get better outcomes. And so there's a lot of research, a lot on magnet hospitals that show they have better outcomes and lower costs than other hospitals. So that's attracting a huge amount of attention in the US, and now pretty much every hospital either is a magnet hospital, about 8% of our hospitals are qualified, but all the other hospitals that are not want to be, and they're working towards it. And so this whole movement has substantially improved care environment. So the net, I think, recommendations of where we are now is that all of our countries, but I've shown you the evidence for Sweden specifically, policymakers and managers should put a high priority in improving the work environment in hospitals. That doesn't cost much. It's a relatively low-cost lever that has a huge impact on quality and safety of care. It's a matter of thinking about things different, empowering workers, doesn't cost money. Magnet recognition is a way that Europe might look at. There are no magnet hospitals here. There are magnet hospitals now in an increasing number of other countries. Standardizing nurse qualifications at the bachelor's level looks like it could save a lot of lives in Europe and even potentially in Sweden. So this is a serious thing that we now have some evidence, and it's something that can be done. It's totally doable if you make it possible for nurses to get a baccalaureate degree. And then we come to staffing, which is always difficult because staffing is a thing that costs money. But our data very strongly suggests and empirically documents that there is more staffing variation in your hospitals that can be justified by in any form. And it's associated with variation in outcomes. So clearly they need to be more evidence-based decision-making on staffing in your hospitals and in hospitals generally. So I know this is kind of like taking a drink of water out of a fire hose, because we have information that is almost gives you an answer to lots of things in healthcare, and I've only brushed over the surface. But I think now we have some very powerful data. And by the way, one of the reasons why we were so anxious to do RN forecast was our observation that nurses get to the table when they have data, and numbers count. And most of the numbers we have in healthcare are financial numbers, right? They're what things cost. And so in all of our systems, managers that have the numbers about what things cost are the ones that are making decisions. Okay, but now we have information on what counts for patient outcomes, so we're hoping that your organization, you as individuals, will take these data and use them to drive change in your own organizations, clinical organizations, and with your policymakers, because now you have plenty of data, and probably more data than anybody else on healthcare in Sweden, to be at the policy table. So let me see what your ideas are, your suggestions for future things we should study, your impressions. And thank you so much for giving me this opportunity.